So Wallace Akerley, and I'm from the University of Utah, Huntsman Cancer Institute. And I really don't have any disclosures related to what we'll be talking about today, just clinical trials. Talk about non-small cell lung cancer, a little bit about precision medicine, and then recent updates. Sounds sort of redundant, but I'll be talking about updates in lung cancer, largely restricted to metastatic disease. I'll start with molecular, and then I'll move on to immunotherapy. So lung cancer, just since we've been talking about so many other cancers, we'd come back to lung cancer, the most important one. Number one cause of cancer death nationally and in Utah. Utah has the lowest smoking rates of smoking in the country. Consequently, it has the lowest rates of lung cancer. Despite that, number one cause of cancer death in the state is still lung cancer. Now, everyone shows this curve, and this curve is important to me. You see that we know that smoking decreased in frequency, and consequently, you see this decrease in the death rate. So everybody pays attention to that right side of the slide over there. But in the state of Utah, where we do smoke less, despite the fact that we're still at almost a 10% rate, just breaking below it, the important part to me for this lung cancer survival curve is the left side of the curve. If you look at that left side of the curve, you see that the death rate for lung cancer back in the 1900s or so is much less than everything else. So the point is, if we really can work on cigarette smoking, we can go ahead and make lung cancer kind of an unheard of cancer. So the left side of the curve is important to me. Precision medicine has been talked about already today. The key piece for me is that lung cancer was sort of leading the way, but not really doing a good job of it. We were a bit false, I have to say. So the NCCN guidelines, as recently as 2016, so 2.5 years, we still had one kind of cancer, and treatment was easy. Everybody got a doublet chemotherapy. When that didn't work, you got a singlet chemotherapy, and when that didn't work, you jumped into erlotinib. So that was sort of where we were still in 2016. Now, granted, there were ALK and EGFR mutations, but the truth of the matter is penetration or testing was really low. It was in the 20-ish%, 27% kind of rates back then. But more important than that, is erlotinib. We actually didn't necessarily use it for patients with EGFR mutations. We used it for those who had mutations, but we also used it for wild type, so we just gave it to everybody. So while it was a targeted therapy, it was very far from precision medicine. Where do we stand now? Well, clearly, we have multiple different types of lung cancer. We define them by molecules, we define them by immune categories, and we define, and we have the leftover wastebasket group of wild type, but we'll keep picking more groups out of that as we go by. Standard therapies now for molecular, EGFR, ALK, ROS1, BRAF, all standard therapies at this point. On top of that, there's really good data, and NCCN makes recommendations, while they don't give a pathway, to consider therapy for RET, MET, and HER2. We'll go through these in order. Immune therapy we'll cover, but everything at this point is defined by PD-L1, but those lines are blurring. PD-L1 therapy as a single agent, PD-L1 therapy with chemotherapy. Also considered for wild type, we still have single agent chemotherapy. At one point, we didn't have to talk with our cancer patients too much in the sense that they didn't ask tons of questions. I used to be a breast cancer doc years ago, and my patients asked thousands of questions. I felt it a bit of a relief when I got to go and move into lung cancer. Now my lung cancer patients ask every bit as many questions. So this is a construct that I'm using with my patients right now. We make cancer. Lots of broken genes, that's what cancer is about. And DNA repair fixes it. Those that get past our DNA repair mechanisms, we talk about, immune elimination. That's going to get rid of them. And so the goal is, if you really want to understand the cancer, can you understand what are the things that help make the cancer, or how the cancer circumvents our natural defenses? So clearly a molecular panel, and we believe in broad-based molecular panels. Immune elimination, presently we're doing tumor mutational burden, PD-L1, But I suspect in the next couple of years, we're going to have 8 or 10 different measures of this. There's already a number that are being looked at. So on to molecular therapy. This is my clinic just several weeks back, but the point was I picked this out that day. I looked at my clinic. I only take care of lung cancer. Those with EGFR, ALK, non-smoker mutations, they typically live around 3 years. Those who smoke, unfortunately, live a little better than a year for average. And so the point is, in my state where we don't smoke so much, we see lots of mutations. And the patients who have the mutations live a long time. So they concentrate. And the point of this is, if you kind of look at the list here, you'll see that 2 out of 3 patients had some sort of mutation in my clinic, and we hit all of the mutations, EGFR, ALK, MET, BRAF. I missed a ROS that day, and I do have HER2s floating around, but the point is, this is what lung cancer is going to look like, as opposed to when I was a fellow, it was just a lot of smokers in wheelchairs with yellow fingers and oxygen, and this is just not the case. I have young people, physicians, partners that are working full-time and dealing with their metastatic cancer. Very different than where it was in the past. So EGFR mutations, we're all aware, they're different. There are the classic sensitivity mutations, but there's also resistance mutations. T790M is the classic example that we talk about. The clever part is, as time goes by, we get smarter. A resistance mutation becomes the target of science, and suddenly T790 is now considered a sensitivity mutation. So just as we said all EGFR mutations are not the same, well, it turns out all EGFR drugs are not the same also. And this here figure is meant to go ahead and represent the original first-generation EGFR drugs. They were meant to have high IC50s, largely for what we understood. So the protein EGFR we cared about, and consequently, while we were hitting the sensitivity mutation for EGFR, we were also hitting the wild-type great guns. The third generation at this point no longer is aimed at the EGFR receptor in general. It's really aimed at those who have mutations and the ATP binding site. Consequently, again, I was just teasing with some graphs beforehand and looking at rashes that you could see who is on EGFR and who wasn't in the waiting room. Right now, the new generation of drugs doesn't get wild type and much more easily tolerable. So EGFR, continuing on this, osimertinib is the name of the drug. It gets T790M drugs resistant. It hits them well. You can look at this graph and you see, wow, this is pretty cool. We have response rates at the 62% response rate. So that's really high. But if one looks at the disease control rate, stable disease plus EGFR, the disease control rate with this is 93%. We think of lung cancer as, we used to think of lung cancer and pancreas as sort of the same animal. And the answer is 90+% response rates for the third generation EGFR. We're benefiting way more patients, or almost everybody, on first-line therapy. How good is osimertinib against conventional chemotherapy after you've progressed on a first generation? Well, there's PFS differences and survival differences when one compares it to chemo that you see here. How good is it third generation against first generation? Well, what you see here is survival. Let's see, that's progression-free survival, markedly improved. How about crossing blood-brain barrier? Well, for those who have who have brain disease in the first place, you see hazard ratios on the order of 0.47. You look at it in those without, the hazard ratio, though I can't see it, I think is 0.46, exactly the same, whether you have brain metastases or not. And the bottom curve over here shows overall survival. Now, if you, you can see the curves separate. I heard the term slide a sliver of paper between it a few times. The answer is you can easily slide a piece of paper between that and probably a short stack. However, if you look, you'll see a hazard ratio of 0.63, pretty impressive. However, the p-value, while it was at 0.007, A pre-specified correction for multiplicity said, oh, you had to be better than that. So while there is no improvement in overall survival, because all of these patients crossed over, the answer is, I believe there will be. It's just going to be a little bit of time before we see it. So where are we with EGFR? The issue is, well, what do you do after osimertinib? We just took away, so what I said before was Tarceva or erlotinib or gefitinib became drugs of historical interest only, largely, in my opinion. Everyone should be getting osimertinib up front. Where do you go there? Well, biopsy mechanisms to look for mechanisms of resistance have shown us a few things. One, there is a small cell transformation, not that common, reported at 14% initially, 9% in another study, less than 5% in another. It's relatively uncommon, but it happens. I've seen two. MET amplification is the next one that we'll be looking at. Whoops, and just this year at AACR, the TATAN study reported savolitinib plus osimertinib, but only in those patients who had a MET mutation that showed up secondarily on top of an EGFR. The cool part about this was if you had progressed on a first-generation EGFR drug, you got a 50% response rate. If you progressed on osimertinib but went back to osimertinib and savolitinib, you had a 25% response rate. So the concept that people are pitching after osimertinib, nothing else you can do, the answer is if there's a MET mutation, you should consider biopsying and you can look for it. This year's ASCO, another one that was exciting to me was J&J 372. This is a bispecific antibody, again looking at MET, but it binds EGFR and MET. And when given to patients who'd progressed, you see here, you can see here that there are response rates in 28% of patients who had previous osimertinib third-generation drugs. So kind of cool data. There are things that can be done while it's not on the market. It is a strategy that I think we're going to go and see in the next little while. This is an old one, this year's ASCO again, a strategy that's been tried in the past, but I think we'll do it again in the future. So a first-generation EGFR given to patients plus or minus chemo. And while it was done with gefitinib, it showed a striking improvement in both PFS and overall survival. The moderator at the session talked about how good the PFS was as it was approaching 18 months, getting to be where osimertinib is. But the challenge is osimertinib's at 18 months for PFS to begin with. And so I think this was a great study, gives us a strategy, not a drug. I think this will have to be repeated with osimertinib, but we may even do better with these patients in the near future. On to ALK. First generation is crizotinib. Everything else in my mind is kind of a second generation. Every one of these drugs has been tested against crizotinib. Anything can beat crizotinib, it sort of seems. However, where do you go with the second generation drugs? Which one of them should you use first? A pattern that you'll see just like EGFR. So in this particular study, the ALEX study, they looked at alectinib versus ceritinib. And you see here progression-free survival much better with alectinib. Second figure shows rate of brain metastasis, and you see that the control of brain metastasis is much, much greater with alectinib. Second generation drugs, alectinib does get through and give you better brain control. So even if it didn't give you improved OS or PFS, the fact that it can help your brain is kind of who we are. That's impressive. And then finally, last demonstrates overall survival. And it shows some benefit, not quite there yet. What's the right answer? Not sure. They're moving on to look at what do you do next. And so this is resistance mechanisms of interest for ALK, a little more harder. For EGFR, T790 was half of the mutations that showed up. So you had one that you had to deal with in the number of patients. Now, all of a sudden, you look at that list over there and you see, oh my goodness, there's a ton over here. How do we make a drug for every one of these? Well, it's not clear. But there are certain mutations, and it gives you a strategy. One could go ahead and biopsy and look for the second mutation to show up. An alternate strategy is to just look at this group of second-generation drugs. And this was an interesting single-arm study, treated everybody the same, but it was those patients who'd progressed on first-line first-line ALK drugs. Could have been first generation, could be second generation, but it at least gives us hope. When you look at those who'd had a first generation only, there's a 90% response rate to a second generation. Pretty cool thing. Secondly, if in fact you've progressed on a second generation, there's still 70%-ish chances that you may end up with a response. So you can give a second drug. We don't have a great strategy. This drug, lorlatinib, gets in across the blood-brain barrier extremely well. And I have patients with leptomeningeal disease who are doing quite well on lorlatinib alone. ROS1, nothing new here. Crizotinib is the drug. There are a number of other drugs that will be coming, but I don't think there's enough to go and change the standard just yet. BRAF, we've stolen from melanoma. Dabrafenib, trametinib are working fantastically. Patients are doing well. I'm not going to jump on that one. That jumped all by itself, though. Just to say that there are drugs for BRAF mutations. Still single-arm studies. I think it'll be a while before we get around to anything that's randomized. Let's see. MET mutation is another mutation that we're looking for, and it can be treated quite well. We're participating in the geometry study, which is capmatinib for MET exon 14 skipping mutations. It reported response rates of let's see, previously treated. Oh, so I'm sorry. So it's in the 70% range, but in previously treated capmatinib is 40%, disease control rates pushing 80. Patients who are untreated, 70%. So MET mutations, high probability of response, and we said disease control rates can go 96%, approaching 100. RET rearrangements, we're also participating in the LOXO292 study, another one of these that's had dramatic responses. I've had patients with malignant ascites, unable to eat, get better and go back to work. Leptomeningeal patient who's actually doing well on this. Official response rates are in the 80% range. At ASCO this year, another drug was discussed, Blue 667, and in 48 patients, they have response rates that are in the 58% range. And so new drugs are coming down the pipeway quickly. HER2, adotrastuzumab, we can use. We don't even know what the biomarker is. You can use protein, you can use amplification, you can use mutations. It seems the mutations are the most appropriate. I mean, you may see response rates in the 44% range. This year's ASCO breakthrough, in my opinion. So we looked at KRAS. Most of us have characterized KRAS as just KRAS, period. All the mutations we group the same. However, there is a drug, AMG 510, and when they looked at G12C submutations, we're all going to become very familiar with this, subspecific types of KRAS mutations. They showed response rates in 5 out of 10 patients. So while KRAS is the most common gene, there'll be a subset of it we're going to be treating in the near future. On to immunotherapy. And everything I'll be talking about is PD-L1. We'll leave it at that. We're all aware that immunotherapy works. You can take any of the PD-L1 or PD-1 therapies and put them against second-line chemo. And the answer is nivolumab beats it in squamous and non-squam. Pembrolizumab beat in all non-small cell. And atezolizumab did the same. So immuno beat second line. How about first line? Well, has a lot to do with selecting your patients. In the KEYNOTE-024 study, they looked at pembrolizumab in those patients who had PD-L1 greater than 50%, and they showed an improvement in overall survival. It beat first-line chemotherapy. Nivolumab went head-to-head in all comers and didn't have the same result. At this year's ASCO, they looked at pembrolizumab in the KEYNOTE-001 study, first-line therapy, and they reported 5-year survivals. I mean, imagine that, 5-year survivals in metastatic disease. This is not what lung cancer is supposed to be about. And so if you look here, 5-year survivals are 29% if you're PD-L1 greater than 50%, and 149, 16%. Again, just blows me away. 5-year survival in lung cancer, metastatic disease, not something to even be whispered about. So where do we stand right now? The most recent is the Gandhi paper, or the 189 study. This is Pembro plus chemotherapy. Everyone's coming up with their own nicknames, PCP, PEM Carbo, et cetera. It's just becoming the workhorse for non-small cell lung cancer. And this was a study of 600 patients, 2-to-1 randomization. The majority got obviously PEM Carbo versus chemotherapy, with an understanding a large fraction of the patients crossed over. So everybody essentially all got the same drug. But there was a major improvement in survival. Response rates are 50%, disease control rates, again, that I think are the most important. But 85% of patients had disease control. Overwhelming, very different than where we used to be. So improvement in overall survival and in all subgroups. PD-L1 makes a difference. You can see the curves separate out a little bit more the higher the PD-L1 is. Other categories, atezo plus chemo has been shown to be beneficial for squamous. Atezo plus chemo has been shown to be beneficial for untreated non-squamous. EGFR therapy is an important one. So this appears a meta-analysis, and it just shows that EGFR is a biomarker by accident for immunotherapy. If you have an EGFR mutation, you're not going to do as well with immunotherapy as you would otherwise. And so the biomarkers that I talked about in the beginning, we're going to see an array of those falling in. But in fact, EGFR is being used as a biomarker at this moment, and most, in a negative way. Most studies will exclude EGFR and not let you participate in an immunostudy if you have such. So let's see. So there is a recent publication by Rec et al. With a subset analysis of the Empower 150 study. So this was the 3-arm study looking at a quad, kind of expensive therapy, but it was Taxol, Carbo, atezolizumab, Bev, and we're only going to focus on the first chart here. But what it showed was that in the EGFR population, if they were treated with quad chemoimmuno versus triplet chemoimmuno, there's an improvement in survival. Hazard ratios 0.6, quite impressive. Median survival hasn't been reached for those who've been treated. So while EGFR is a negative biomarker for immunotherapy, I think it shows substantial promise and has now become my go-to chemoimmunotherapy after EGFR therapy is no longer working. Lastly, I'll just mention the durvalumab data in stage 3 unresectable. Now, stage 3 unresectable is a curable disease. On the other hand, it's got kind of a 20%-ish cure rate, not overly impressive, which means, by definition, it's 80% metastatic the day you meet the patient. If you believe that the radiation by itself cures on its own, but let's leave it at that. So this here study was an interesting study, clever. Everyone got chemoradiation. They were randomized to then the remainder of the year with durvalumab. And what you see here is a trend towards some flattening of the survival curves. But if you look at the absolute numbers, you're pretty much doubling that 3-year, well, let's see, that 2-year survival that we're talking about there. I do believe these chemotherapies are going to continue. The survival curves will stay somewhat flat, but there's going to be a downward trend. Bottom line, though, those who fail to give this immunotherapy are missing out on the opportunity of cures, and in an unresectable case of lung cancer, it's just one of those things we shouldn't be missing. So in summary, this was kind of an update. Everything has changed in the last 2.5 years. Lung cancers is many different cancers. They can be defined both molecularly and by immunoprofiling. Treatment paradigm, I said, is way different. Molecular is going to continue to show progress. We're jumping into KRAS. At this point, immunotherapy is exciting, but I think combinations of chemo with immuno or second immunos are going to be the important answer. I think we're just scratching the surface and making lung cancer a chronic disease. Thank you very much. And next up.